Cancer is nothing more than a bioenergetic disease. And if we could get to the basis of the cancer bioenergetics, which I feel more confident today than I ever did before, then we can cure it. And the beauty of that is we can probably cure it without toxicity, because cancer has extraordinary vulnerabilities. It really does. Cancer cells are extremely stupid.
Welcome to Metabolic Matters podcast. Let's meet today's guest.
Welcome back, everyone. I am absolutely over the moon with the conversation we're going to have today. I was trying to figure out before the recording started of when I started to know about this brilliant man and started to quietly refer patients his direction to bring more tools and more ideas and more options to my patient population. Dr. Robert Nagourney is a pioneer in the field of personalized cancer treatment. Well beyond what we think of personalized treatment today, this man has been doing this work. He's been interested in this work since the 1980s, has been applying this work in the laboratory since the 1990s and beyond, and has been helping patients with this work for well over 20 years. Dr. Nagourney, it's an absolute privilege to have you having this conversation with us all here today. Welcome.
Well, thank you very much for including me and inviting me.
Absolutely. Well, my gosh, this is a field that I can remember just a few short years ago. In fact, I spoke at a conference at a Colorado Association Ovarian Cancer Conference in 2012. That's sort of when I came out of the closet of someone working in integrative oncology at that space, really out of the closet outside of my tiny little county in southern Colorado. And I can remember a group of oncologists sitting in that room, literally poo-pooing me and vexing me on the stage as I spoke about circulating tumor cells, as I spoke about the future of medicine having the ability to test tissue and blood. And even at that time, I had patients getting these tests, including with you, for many, many years prior to even standing up and giving this presentation to the Ovarian Cancer Colorado, symposium. And so it was just such an interesting time that was only 12 years ago, and no one was ready for that information then. And so really, your career, the entirety of your career, has been really riddled with skepticism. Can you talk to us about how you got interested in truly personalized medicine in the integrative oncology space?
Well, as I mentioned to you once before, I was a fellow at Georgetown University in Washington, D.C. And I had arrived with this great enthusiasm. I had finished my residency program at UC Irvine, and I had come to Georgetown expecting to vanquish cancer. And my patients were not doing very well, and the treatments were toxic. And this is in a period of time where we didn't have growth factors and many of the new antiemetics and a lot of the supportive care that makes it possible to deliver treatments more effectively. So patients really suffered. And my problem was that they were not only suffering through treatment, but they were not getting better. And I had the distinct impression that I was a sort of angel of death for my patients. I couldn't seem to rescue people. And for all of my success in my residency and ability to do all the things I had done, I suddenly confronted diseases I was having no measurable impact on. And I had met a guy who was working in this field. And actually, everyone in the area of cancer, I was doing basic research as a medical student. So everyone who was even remotely interested in cancer had read the original articles about the clonogenic assay. This was the work of Sidney Salmon and the idea that cancers were stem cells and that stem cells proliferated and became tumors. And if you could stop the cells from growing, then that would be the way to pick drugs. And a New England Journal of Medicine paper came out that said, if we stop cells from growing in the test tube using something called stem cell or clonogenic assay, that we can improve the outcomes. And one of the models was ovarian cancer. That was one of the diseases they tested. So I read that New England Journal of Medicine paper with great enthusiasm. I thought, this is going to be great. And I actually created a laboratory to study clonogenic assays, and it didn't work at all. I mean, it was terrible. It was worse than terrible because of a lot of work. And it was contaminated with fungus, and it took weeks to grow out the tissues. The colonies were often clumps. The whole thing was really not working. And the guy that I was working with on this at UC Irvine, my last year of residency, said that he thought it would be a better idea to just kill the cells outright. So that's an interesting idea. So when I went back to Georgetown, when I finally got to Georgetown, I started setting up my second year basic research program. I had the opportunity to set up a laboratory to measure the technique that he was using. This is a staining and morphology measure. And what we were doing was saying, well, if a cell dies, it will commit to this death process within days. If a cell stops growing, it takes weeks or a month to see if the growth slows. So if nothing else, it was just a better way to get to the answer. I had no idea at the time that it was fundamentally different. Cells that do not grow may grow again. Cells that are dead are dead. So there was a finality of the endpoint that at the time seemed more appealing. In addition, there were many kinds of cancers that don't grow. Chronic lymphocytic leukemia does not proliferate. But I could measure in the test tube a CLL cell's response to injury without having to grow the cells. In fact, they were trying to use like Epstein-Barr virus infection to propagate CLL cells just so they could study their drug responsiveness, all of which was very misguided. So fairly quickly, I realized that the endpoint of cell death was much more predictive. And that was when we moved into leukemias. And I did all of my early work in chronic lymphocytic leukemia and acute myelogenous leukemia and acute lymphoblastic leukemia. And we made a very, very interesting observation. Children with acute lymphoblastic leukemia could be determined for their survival by the fourth day of diagnosis if the cells remembered how to die. And to find that out, we exposed the ALL cells from bone marrows in 49 prospective children. We exposed them to dexamethasone, a simple corticosteroid. The children whose cells died from the corticosteroid exposure all went on to unmaintained remission. The survival approached 100%. The children who showed no response whatsoever were virtually all dead within 5 years. So there was something profound about the measurement of cell death that was far beyond a simpler way to do this. It was distinctly different. In the earliest era of the study of the concept of apoptosis, I was invited to speak by one of the great pioneers of that field, John Reed. John was the guy who discovered BCL2 with Carlo Croce. So John invited me to come to a meeting, and I gave my acute lymphoblastic leukemia data. And it was immensely well received. Every scientist in San Diego at this meeting were all over my presentation. They loved it, the idea, the concept, the principle of measuring cell death in human tissue. So I knew we were on to something, but I, up until that time, had not recognized the concept of programmed cell death as a discipline. I just thought this was an easier way to do this. It was during those years that I realized that the process of cell death was the process of cancer. Cancer doesn't grow too much. It dies too little. And if you can measure what caused it to die, you can measure how a patient will respond.
I want you to repeat that. Cancer is not a measurement of... That was really powerful.
Cancer doesn't grow too much. It dies too little. And because of its longevity, because of the durability, the survivability of the cell, it remains in the gene pool long enough to proliferate, but it is not proliferation that drives the cancer. Cancer grows at approximately the same rate as normal tissues. If you put a breast epithelium tissue and a cancer tissue next to each other, they both generally divide or double every 1 or 2 or 3 months. So the process whereby a tumor becomes palpable, measurable, metastatic takes years, decades. The average colon cancer is progressing in the gut for 27 years before a 1 centimeter polyp can be detected. If it is not detected, which is the reason we recommend colonoscopies, then 3 to 4 years later, it has not only doubled and doubled and doubled, but it is now metastasized. So it's identifying the tumor in that doubling period and the earlier the better. But cancer as a disease is not a growth disease. It's a lack of death.
So interesting. I understand that and I see that. I've just never heard it articulated quite in that way. Is this a concept that is adopted or well understood in standard of care oncology today?
Oh, yes. If you look at the original Hanahan paper and all of the hallmarks of cancer, one of the hallmarks is escaping cell death.
Right.
I think it may be the hallmark, but they have a lot of them, immune evasion and alterations in metabolism. And that circle gets bigger and bigger as they define.
That's 20 years,
Remember that if a cell is dead, it can never cause you harm.
Right.
So the fundamental target of cancer therapeutics has to be to get the cell to die. And beyond that, immune evasion, alterations in metabolism, the capacity to metastasize, the ability to develop blood vessels, all of that is irrelevant if the cell is dead.
So I love this because that's just it. And it was 2001 when Hanahan's first paper came out of the first 6 hallmarks that he's speaking to, one of which is this concept of apoptosis, which, Dr. Nagourney is suggesting is really, we really put our energy there. That's where the magic happens. And then a few years later, I think 2011, it expanded 4 more. And then as recently as January 2022, it expanded a few more supportive or sort of entourage characteristics that continue to build out the hallmarks. And the irony of this is, despite us learning more, and you said the circle getting bigger, we haven't made big splashes overall in cancer, prevention or treatment. And so what you're saying, if I'm understanding, is if we put more energy to focusing on programmed cell death, this concept of apoptosis, we'd probably get bigger bang for our buck. And so I'm just intrigued by that because we do keep seemingly looking in other directions instead of that. And how do you, because even though I know those are the hallmarks, apoptosis is, it doesn't feel like it's landed with such brevity that you just shared. How would you explain that?
Well, first of all, and it's very important to recognize that programmed cell death does not equal apoptosis.
Good point.
Programmed cell death is a global event that leads to the loss of viability on the part of a tissue, whether benign or malignant.
Got it.
Apoptosis is a specific activation of downstream caspases 3 and 7 or through other vehicles, and largely dealing with mitochondrial depolarization and the release of cytochrome C and these various events. That is a very important, but certainly not the only process of cell death. And one of the problems in this field is that people latch onto the tail of the elephant and decide that that's what drives the elephant. And it's not. It's not. The trunk of the elephant is necroptosis, and the tusk of the elephant is PARC mediated. And the other ear is another form of cell death. So these necroptotic and autophagic and apoptotic measures must be incorporated if you're going to find the thing that leads to the cell death of that patient's tumor. We find this is studies done years ago, when people were very focused on apoptosis because they were using models that were driven by apoptotic cell death. When people were first starting this, I was at the phase 1 meetings in Washington, D.C., and there was a very interesting series of presentations because apoptosis became everybody's favorite topic. So I was sitting in on discussions, and they were making the point that if you introduce chemicals like ZVET, which is a inhibitor of caspases, the cells that have committed to cell death will die by necrosis. So the idea is you can't just measure one piece of this. You have to measure, which is why I think the more global measures, we like to look at bioenergetics. We like to look at mitochondrial function. We like to look at ATP content. We like to look at morphology. We like to look at the loss of membrane integrity, because these are global measures of cell death, whatever pathway. If a cell is dead and it is unable to maintain membrane integrity, ultimately, all biologic existence is predicated on self, non-self. And the distinction between you and the rest of the world is your membrane, or as a multicellular organism, as a metazoan, all of your membranes together. So where we meet the world, which is, our skin, or where we meet the world, we distinguish ourselves by maintaining the integrity of our bodies. That's why we don't dissolve when we go swimming. And cells in the body are maintaining their integrity at their cellular membrane level, and that is largely ATPases. So energy is essential for the membrane to stay intact, for the cell to stay alive, and the loss of membrane integrity is one of the most discriminating features of cancer cell death.
Wow. And this is what's so wild is at the time that Hannigan's paper came out about the hallmarks, we were still not, at least in clinical environments, maybe in research labs discussion. In clinical environments, we were not understanding, like I would still even say today, and please disagree if I'm really off base here, but my whenever I'm at a medical conference and I'm presenting to fellow clinicians, I'm always asking, did any of you learn beyond the function of the mitochondria, that the only thing the mitochondria does is produce ATP? I think we were all taught that in 6th grade biology of, the mighty mitochondria, and this is its only job. And it wasn't until the last 15 to 20 years that I started to run across more research and more understanding to realize that the fate or the function and the utility of our mitochondria are also very much in charge of this apoptotic process. In fact, many would say and suggest in the literature that shows it, that a proper functioning mitochondria is what's in charge of that process. And so that, of course, is what fires me up around the metabolic approaches to cancer. But what do you say about that? Because I don't think this is common knowledge still today, even among med students from the students that come through my practice who come in preceptor and do residencies. I'm not seeing these conversations.
Well, as you know, Lynn Margulis, who was a professor of mine,
wow,
and a friend who tragically died a few years ago, was largely eschewed for her opinion that the mitochondria were microorganisms living within each of our cells. And she called the process endosymbiosis. And she coined the term. And I just thought it was fascinating. And luckily, I had her as a sort of a mentor when I was doing basic biochemistry in signal transduction in my undergraduate years.
Wow.
And I became friendly with her because I thought she was so cool and so interesting. Anyway, nobody seemed to want to admit the fundamental nature of mitochondrial function within the cell and the utter dependence of the human biology on their mitochondria. So she kind of left. I was at Boston University. She went to UMass, and I really kind of lost touch with her, and I wanted to reconnect with her. But the point is that if you look at mitochondrial function, it is not only bioenergetic. It's not only ATP is just one little piece of it. The NADH oxide reductase and the complex 1 through 5. Yeah, they're generating energy. But it's making a substantial percentage of all the biomolecules in your body. Mm-hmm. The lipid metabolism and the interaction, the citrate cycle, the interactions between glycolysis, lipid metabolism, how the citrate is spun off to make lipids, how the lipids are then metabolized through the transfer by carnitines. The mitochondria are fundamental to our existence. And there's no question that they don't just make energy.
This is huge. And, again, even though you see that, you've had one of the original researchers speaking about that. I've never met her, never heard her speak, but I've read her work for sure. It's still really strange to me that it's still not a sort of accepted or understood concept. But I do think it's changing. And I'm just curious of where you think, where that turning point happened. When did we start to maybe see this? Not just in the research, like at the bench, but when did we start to actually see it, understand it, and apply it at the bedside? Or have we?
It's interesting. I think that medical science advances in sort of a very episodic way. And so if you look at cancer research, we started off with interest in enzymology. The 1931 Nobel Prize awarded to Otto Warburg was largely focused on cancer enzymology and on respiration. The 1937 Nobel Prize for Shant-Gorgi was also on citric acid, the discovery of vitamin C, the citrate cycle. The 1953 Nobel Prize for Hans Krebs on the Krebs cycle and the urea cycle. I don't know if everybody realized that, but Krebs was responsible for all of these things. So we have a a backdrop of incredibly brilliant scientists. But what happened probably on a trajectory from 37 to 53, when we might really have done this right, what happened was the discovery of the structure of DNA.
Yeah.
And all of a sudden, biochemistry, physiology, stoichiometry, and all of the brilliant work that had been done by all of the brilliant scientists was thrust aside as we said, well, the answer's all in the gene.
Wow.
And so in 1953, in April of 1953, when Francis Crick, when they published, what I think to their credit, a one-page paper describing the double helix. In any case, when Francis Crick and Watson Crick published that, Francis Crick went out for a drink and he said, I've discovered the secret of life. Now, if we go back the 71 years since that, it's still a secret. And the reason it's still a secret is because it isn't the secret of life. This is informatics. We need biochemistry and three-dimensional biology. We need to return to the platforms that measure physiologic phenomena. Sometimes people ask me what I do, and I say I'm a cancer phenomenologist. I'm interested in the event of cancer, not the origin of it. The origin of cancer is of interest, but the fact of cancer is manifestly more interesting and more productive as a study. In a way, I mean, if I said to you, Nasha, I have an option for you. You can either cure cancer or discover how cancer arises. I'll cure it.
Right.
Someone else can figure it out, which is the way I feel. Someone else can figure out what I did. As long as I cure it, or cure as many people as I can, I don't need to know the intricacies of every aspect. And I did a TED Talk some years ago, and I showed the biochemical pathways that are involved in cancer and life as we know it. And I said that it's way too complicated for most people to figure out. So they want to drop back to the simple structure of base pairing and the informatics of DNA because it's so seductive and it's so easy and you can get your arms around it. The trouble is things that are this complex are complex. I mean, it's a tautology that it isn't easy. That's the reason all these gene tests aren't doing much. I mean, the more you really dig into this, the less you like genomic profiling.
Well, and that's a place is maybe for a moment, help the listener understand you've got a variety of ways now that we can look at the tissue beyond just pathology. And we can even look at tissue from blood cells or from fluids buildup in parts of the body, not just, fragments of tumor tissue. Describe like what we can now look at today, like maybe just categorize for us, because there are certain companies out there that just look very myopically at only one of those buckets. You do far more than that, but could you just maybe give a quick primer of like, what are the main buckets that we're looking for in blood or tissue assays today?
It's sometimes it's easier for people to understand sort of an analogy.
Okay.
So imagine instead of trying to find the cure for cancer, you're trying to locate someone's address. So you start off with a Google map, which is like from 100 miles off the surface of Earth, and you get this topographic map of where you're looking for. And it sort of tells you that North America and South America are connected at an isthmus. And you get this sort of general idea. So then you plug in the address and it kind of zooms down and you suddenly find yourself in Ohio. And then it zooms down and it's Cincinnati.
Wow.
And then it zooms down and it's the Carew Tower. And then you finally get a photographic image and you're sitting at the Palm Court in a lovely Art Deco environment having a coffee. So DNA is like that first pass. I'm not saying it's bad. You want to know where Ohio is, but you will never get to that coffee place from a satellite map.
Wow.
So you start with your overview and you keep drilling down. So you can imagine it's genomic to transcriptomic to proteomic to metabolomic. And that's metabolism. So physiologically, there's no way that DNA can tell you anything. It's like saying to someone, it would be, we know that obviously genes are profoundly important. I'm not saying that we're not products of our genes, but the product of the gene is largely mediated by the interaction between your environmental factors and your genetic factors and how you play this. And I often say to cancer patients that your genes are dealt to you. But if you've ever played cards, you'll know that you can win a hand with a pair of twos and lose one with a straight. You've got to know how to play the game.
Wow.
And the game of life is, what do we do with these genes? Now, the first pass, of course, is epigenetic, but that's very complicated because epigenetics is methylations, histone methylations, histone acetylations. But even beyond that, it's non-coding DNAs interacting with interfering RNA. So there's so many levels before you even get out the nuclear pore. There's been a litany of interactions between that gene product and the ultimate thing getting out of the nucleus. Okay, once it arrives in the environment of the cytoplasm where the protein synthesis has to occur and you make these enzymes, well, those enzymes, whatever you're going to make is highly dependent on ribosomal function, at the end of which these proteins are going to be either grabbed a hold by a chaperone, like an HSP90 or HSP70, and they're going to be chaperoned to functionality, or they're going into the carburetor at the Brody cell. Wow. So then they have to be glycosylated and phosphorylated. So it's kind of ridiculous to imagine that this gene profile is going to tell you what an end result is going to be. It's like someone finding out they're left-handed and being quite sure they're going to win the World Series as a pitcher. There were way too many things that go into that,
Well, first of all, that is just brilliant. Brilliant. I've never heard it articulated in this way. But it also takes me back kind of like a zoom in, zoom out of thinking about, for instance, when we were looking at circulating tumor cell DNA, that's that description of like the zooming far out, like the Google map, right? It's like the potential of what could be expressing. And then when we started going a little deeper into the microRNA, that was more of, okay, well, what may be actually, like you said, what's interfacing in the environment itself, which may be more likely what's expressing. So a little closer to the copy, moving into that. What else, how do you test? How would you describe your method within that beautiful analogy you just shared with us?
Well, you want to start with the satellite map.
Yeah.
There's no reason not to know the relative juxtaposition of North and South America. So you start with that. And I'm in favor of running genomic profiles on everyone. I like transcriptomics. I like proteomics.
Yeah.
But the thing is that none of them are discriminating enough to tell you what to do. So you use these as tools. And the problem with people in this field is they silo. Yeah. So they say, well, I'm a gene guy. I remember one time I was working on how to affect KRAS farnesylation. And I went to a very, very, very accomplished investigator. And he was at Georgetown at the time, and I had already left. I think I was at Scripps or something. Anyway, and I said, we're a great guy. Neil Rosen, terrific investigator. He's a major player at Sun Keller, a great guy. And I said, Neil, I've been kicking around this idea. I've been at an AACR Social Symposium, and a colleague and I were talking about measuring RAS activation and blocking RAS activation. And I said, Neil, I'd like to study RAS a little more, and I don't have the potential right now. You have a laboratory doing a lot of electrobiology. Could you look at RAS? And he said, well, I'm really working on MYC, the onc gene MYC. And he said, anyone who does more than one onc gene is a true Renaissance man. And I thought, oh my God. If we're that siloed, we only do one gene, well, that was partly because of the technology. We didn't have NGS.
True.
So you had to spend a career looking at how you would isolate gene products from one gene.
Right. And NGS against next generation sequencing. So
the point is that's the starting point. Now, recognizing that the presence or absence of a KRAS mutation is only the starting point, we now realize that each KRAS subtype the KRAS G12V, KRAS G12D, or the 13 KRAS G13s are biologically different, even though it's supposed to be the same pathway, right? It's not. They're not. So the way I see this is instead of top-downing your science, like, well, KRAS and KRAS G12D, if you bottom up this thing, you're looking at the end result of it. You start with the answer and work back to the question. So what we do is we look at a drug, I have some very interesting examples of that. I wrote a blog today, circulated on the Nagourney Cancer Institute blog, if anybody wants to read it. And it's about a woman who came to me who could not have been more ill. And her doctor said, can you possibly help this woman? She was falling apart. She was just riddled with cancer. I didn't know what she had, but it was obvious to me it was cancer. She had a big cigarette history. So we did a biopsy. It was non-diagnostic. So I said, okay, we're going to need a more generous biopsy. And she underwent a large enough biopsy for me to get a piece of it. Within a few days of studying this patient, I already knew that she was responsive to the KRAS active drugs, the new class. But furthermore, that she was specifically sensitive to the KRAS G12C, which is a subgroup, or two commercially available products that go after KRAS G12C. So 4 days after her surgery, I knew that this was lung and how to treat it.
Wow.
It took weeks to get the gene profile back that did nothing more than confirm what I already knew.
Wow.
By the time we got her gene profile back, I had already long since started the process of getting the drug, which is FDA approved.
Yeah.
And I got a call last week from her internist who referred the patient to me. And he told me how dramatic her response had been.
Wow.
And I made the point to him that in the papers published, Pasejani, who's a very good scientist, wrote a paper in New England Journal of Medicine a couple of years ago on this particular drug, adagrasib. And I, of course, read it, and I was very interested. And the response rate was 43.9%.
Wow.
Which is, that's not bad for a lung cancer patient, metastatic disease with treatment. But in this patient's case, since I had assayed her response rate was pretty close to 90%.
Wow.
Because the laboratory analysis doubles response expectations. So when physiologic measure of responsiveness discriminates a responder from a non-responder, it doubles the likelihood. So when I went to this patient's husband, who was distraught by the collapse, it was why she had fractured her hip, she had fractured her arm because of the cancer. And he was distraught. And I said, don't worry. When I get this drug, she'll get better. And I felt confident. And I got a call from her doctor who said it was miraculous. Every measurable area of disease on a matter of weeks had disappeared. Now, the naysayers would say, well, if you did the G12C, you'd know to give it and all that stuff. But remember, they're still at 43.9%, even if you select based on that. In my hands, it's pretty much a 90% response rate.
Wow.
So the discriminating nature of tissue physiology, of human biology, of three-dimensional biology is much greater than any of these static platforms.
Wow. Unbelievable. Tell me give me another example of, because one area that you have keen interest in is one that is really a difficult area to focus in, which is that of pancreatic cancer.
Yeah.
I know you were doing some really innovative work in this place. Can you tell us a little bit about that? Because this is actually one of the sort of the bridges of you making some transitions in the way you test these days. Could you tell us some examples of where you are moving in that arena?
Pancreatic cancer is one of the most difficult cancers. Everyone knows that. There's 64,000 more or less cancers, 51,000 more or less deaths from this disease. The tiny percentage of people who are found early have a poor survival. The vast majority of patients who are found late have no survival. It is a 1% 5-year survival. So we need a lot of help in pancreatic cancer. And there are entire organizations that are raising money by the tens of millions, having no impact whatsoever. Not surprisingly, they are only almost uniformly driven by gene profiling.
So they're doing that Google map view.
The satellite map of cancer.
Yeah.
And they're pushing it and pushing it and pushing it. And they have, if people who get pancreatic cancer will know these organizations. They pop up on every website. The reality of pancreatic cancer is that it's not a matter of your genes. 89 to 92% of pancreatic cancer patients have a KRAS mutation. 50% of them have a TP53 mutation. About 30 more percent have CDKN2A or B. Another 20 or 30% have STK11. And it goes on and on. And no matter what your gene profile, everybody gets FOLFIRINOX. I mean, if these gene profiles were affecting anything, everyone would be pigeonholed into some sort of treatment. They're not at all. They're not at all. I read a paper, actually, wrote a blog about it a few years ago. There was an analysis. And they were looking at why people chose FOLFIRINOX and why people chose gemcitabine and Abraxane, which are the two principal treatments today. So I thought, well, they'd be based on some biological feature or measure or something. No, it turned out that it varied if you were at an academic center or not, your age and your geography. If you were on the East Coast, you were more likely to get one or the other. I mean, it was patently ridiculous. I mean, you get a treatment because you live in Ohio or Cincinnati or whatever. I couldn't imagine a sillier way to pick treatments. So yeah, we got very interested in pancreatic cancer just because it's such a need. It's such an unmet need. So what we started doing many, many years ago was taking our pancreatic cancer patients to surgical biopsy. I mean, if you're going to die of a cancer and someone does a laparoscopic biopsy to help you, it's worth it. It's worth a day surgery to find out what to do. And when we find winners, they win. I've actually, and it's hard to believe, but I've actually cured metastatic pancreas patients. It's not common. I don't want to say it's a high likelihood, but if you find the right patient, the day they walk in the door, you can cure them. And we have. And I have patients, I have one particular patient now who's 15 years. And I had no idea that I could treat him when I met him. In fact, I thought he was too ill to treat. But we took him to biopsy. He was exceedingly ill. He was requiring, it was 1 or 2 liters of, 1 liter of saline every other day. And he was on 200 milligrams of morphine a day. And his liver was riddled. And he went to all the local, LA is riddled with cancer centers. So we went to all the named cancer centers, and every one of them told him to go home and get his affairs in order. Somehow or other, his wife, who was a nurse, learned of me, came to me, and we treated him, and he went into complete remission.
Gosh.
And the funny thing is that his wife knew only too well what the life expectancy was. So when I finished the first 6 months of treatment, she said, we're not stopping. So we continued on a widened schedule for another 6 months. It was a year. She said, no, we're not stopping. So this saga of sort of maintenance therapy went out for years. And in point of fact, in retrospect, it was probably a good idea. Because in my experience, when you cure someone of an incurable disease, never take that for granted. Right. So the patients with whom I've had the best outcomes, the people who came to me who were considered truly untreatable, when I have been fortunate enough to get them into remission, which I've done, those are the people I keep on maintenance therapy for prolonged periods of time. One patient with ovarian cancer alive today, 25 years later, given up on, was on a maintenance therapy for about 2 years. Maintenance therapy, by the way, is back in style on ovarian cancer. So it's like the width of your tie or the length of your skirt. It's all style, not substance.
Oh my gosh. Well, remember when Avastin was soup du jour in that arena? And we see these things come and go. You've been at it long enough. You're right. It is like the length of your tie or the length of your skirt, unfortunately.
Well, it's not only that, but you think about how important VEGF was 15 years ago. It was the end-all, be-all. Who was it? Watson said that VEGF would be the cure of cancer. All of these overstatements, because it's the treatment du jour. Exactly. And I love Avastin. I use it. And I appreciate the fact that we have the access to it. And it is good. But if vascular phenomena with a cure of cancer, we'd have cured it with VEGF or so clearly there is a more profound fundamental driver of cancer. And that is ultimately viability. cancer cells staying alive, clinging to life. And if you can get that cancer cell to die, it doesn't matter about vascularity, it doesn't matter about immune evasion, metastasis, all that stuff doesn't matter.
Doc, it's interesting because, you kind of started out in the gene pool, and you kind of from that high, that high viewpoint, and have worked your way in. When did you feel like you made that? I mean, you were because you and I've had many conversations at this point. You started getting curious about or recognizing or even playing with the concept of metabolomics. First of all, can you define that for our listeners? And second of all, when did you expand into that space, and where are you with it currently?
Well, I was a student of chemistry. I have a degree in chemistry.
Got it.
So when I went to medical school, I viewed our studies of human medicine through the lens of chemistry. And so to me, the greatest class of all was biochemistry. I loved it. I did graduate level courses as an undergraduate. I was a chemistry degree, but I was working in a laboratory with an investigator who had trained with Hans Krebs.
Wow.
And I became very interested in the chemistry of life. And no sooner did I get to medical school, but I realized that all my smarts in chemistry couldn't hold a candle to the complexity of the chemistry of human biology. That my idea of solving the equation, like I just about flunked my first biochemistry exam because I thought I would just work out the stoichiometry of chemistry.
Wow.
No way. Chemistry is the phenomenon of unlikely events occurring. Substances and compounds interacting, SN1, SN2, these sorts of chemical reactions can't possibly occur fast enough or at a time needed without the advent of the enzyme. An enzyme is nothing more than something that pulls two things together and says, you guys got to meet. And by introducing enzymes into biology, you suddenly take unlikely events and turn them extremely likely.
Wow.
I don't know if people understand the enormity of biochemistry, but just one of the enzymes in the Krebs cycle, succinate dehydrogenase, converts succinate to fuminate 250,000 times a second. 250,000 times a second. There's no way you're going to work that out with a pencil. So when I got to medical school, I said, okay, I'm outgunned. I can't figure this out. So I had to just learn it. I just had to memorize it. I couldn't figure it out. And I mean, that's humbling, but also smart. Because you see, a lot of people today have this hubris about being able to figure everything out. Like the gene guys are the worst. Like they're sure that they've got this thing figured out. But the point is that it is that complicated. So what I began to realize is, okay, I can't work this out. I can't do the stoichiometry. I can't come up with that process by which one substrate will become a byproduct or whatever. So I said, we need metrics for all this. We need dimetrals. Now, at the same time, I was going through my cancer research and I was developing an understanding of cancer biology and cancer treatment. And I finally got involved in this tissue culture concept. So I began to say, okay, cancer treatment, select drugs, use tests. What is the test measuring? Well, it's measuring the collapse of a cell at a level of biochemistry.
Wow.
So I began to realize that the cancer response in a tissue was ultimately a biochemical event. There was a loss of membrane integrity associated with a loss of ATP. And when the ATP dissipated, the cell could not maintain self, non-self, collapsed on itself and stained differently. So the first endpoint I used was differential staining, morphologic assessment of the differential staining of cells. And I didn't really necessarily put this all together more than to say that it worked, which for me as a therapist and as a fellow, if I could take patients who had failed therapy and get them in remission, I was happy.
Right.
Yeah. Being a good doctor was really good, but it stuck in my mind that I was measuring something more fundamental. And I'd always been interested in the chemistry of life. So I said, well, if we're going to measure cells dying, and the cells appear to die by some sort of metabolic or biochemical death, then we really ought to get into the measurement of these metabolism phenomena. And the field of the study of metabolism is called metabolomics, like the study of genes is genomics, and the study of RNA is transcriptomics, and the study of protein is proteomics. Well, the study of metabolism is metabolomics. And funny enough, there's a lot of people have a hard time saying that word. One of my colleagues can't say it. I had a girlfriend who used to call it Yosemite. But so people just can't say metabolism. I don't know why. Anyway, regardless, the field is ultimately putting metrics into this incredibly complicated phenomenon. And so I desperately wanted to do it. Now, the field of metabolomics has really jumped to the forefront based upon fundamental new, really bioengineering phenomena. If you think of most scientific discoveries are not smart discoveries. They're technological advances.
Right.
I mean, people have looked at the moon for millennia, but until they built an Atlas V rocket, they couldn't get there. So it didn't matter how smart you were. I mean, Da Vinci and all of the people who looked up into the skies and all the smart people could not do things until we figured all this out. Da Vinci had spiral corkscrew helicopters, but they didn't work until Bernoulli talked about the principle of gas movements and the pressures that elevate a helicopter blade. All the things that work because of a technological advance. So I was waiting in the background for some technological advances that would enable me to drill down onto the biochemistry of life. And I was desperate to move into the field of mass spectrometry because I felt for the first time we had established a technological capability that allowed me to test what had previously been hypotheses. So when I said cancer cells die biochemically, I could then go into the culture media and look at the biochemical metabolites and predict survivorship from the tissue culture. We have published and presented observations that the ovarian cancer cells making and using energy can be measured, and that tells you if the patient's going to go into remission and be cured. So the concept of metabolomics became so appealing. Now, in its earliest stages, metabolomics was still constrained by an inability to quantify. You see, most mass spectrometry until the last decade or two was finding things the same way that someone comes into
generalization again, like that moonshot again. Yeah.
No, but also just finding it. It's like finding the fingerprint. So you'd say, okay, we've got a fingerprint. Okay, who is it? I don't know. We got to go to Quantico and the FBI has to match it. If we can't match it, then it's just a fingerprint. So you see, you need it to bridge the identification with a metric. And what was so important in the last decade or so is that when you do mass spectrometry, and for your audience who don't know much about mass spec, let me just explain. Mass spectrometry was first developed in 1911. It was used largely in chemical species identification by transmitting charged particles at high speed through an electromagnetic field so that the charge, speed, and density of the particle, the mass and charge of the particle, would deflect it into different places. So that if you sent iron, that was going to go to a different place than sodium or whatever. Cool. So you could begin to develop, this is iron, this is zinc, this is copper, this is sodium, this is chloride. And that technology moved forward as a metallurgical and chemical, and even in the field of forming and all the things where we're like measuring things in the soil and looking at nitrogen balance and also. So we were doing chemical species, but largely we were looking at the presence or absence of whatever you're looking for. Like, for example, if you wanted to know if there was some, for example, someone goes into an emergency room and they're unconscious. Well, they can do mass spec and they can look for the presence or absence of things like opioids or
toxicology,
or whatever you're looking for, right? Or Tylenol, or whatever. And then they can say, oh, okay, this looks like it's this or that. But it's just a little peek. It just says it's there. The breakthrough in a medical context came when we could add an internal standard. And that is what today is known as targeted mass spectrometry. So what you do is you introduce a tiny quantity, measurable quantity of what you got. And when you whiz this through your mass spec machine, when it lands, it's bringing along with it a little teeny little amount of whatever it is you started with. So if it's glutamine, you've got a tiny quantity of glutamine next to it. And you can say, okay, there's the peak for glutamine. This is how much I put in. A multiplicative factor tells me how much is there in this tissue sample, blood, urine, saliva, whatever.
Perfect.
So the breakthrough that has been so exciting for us is the field of quantitative or target mass spectrometry. Now that we've done that, we can begin to bring metrics to this field. We no longer say, yes, it looks like it's this. We say, it is that, and this is how much it is. Now, the beauty of that makes it not only possible to put people in ranges, like is this the normal range below or above?
Right.
What's really been powerful for us in our field, pancreatic cancer moment, we can now develop ratios of different metabolites. You can't do that with a peak.
Right.
Like if you got a peak, it just says it's there.
Right.
But if you quantify the peak, then you get a number and you divide it by another number. So we published a paper in OncoTarget in 2018. This was my proof of concept.
Cool.
And I remember when we wrote this paper, I remember sort of being unable to believe what we were doing. It would be like Jonas Salk saying, nobody got polio. It was one of those immense breakthrough feelings for me because we were taking glutamate and looking at their quantified ratio and identifying the presence of breast cancer, the prognosis of breast cancer, the survival of breast cancer, and the response to chemotherapy, not just on that ratio, but predicated on ratios of metabolites that we could now for the first time measure.
Amazing.
So the advance that so breaks us away from everything before is the possibility of quantifying life. We can quantify life. And I know that sounds vaunted, but I've saved people's lives. I've made discoveries and I've developed treatments that have changed the history of cancer medicine. Not that anybody particularly gives me credit, but that's actually true. The introduction of platinum and hepcidamine, I invented. The original use of the first treatment, meaningful treatment for low-grade lymphoma and CLL was cytoxin fludarabine. I developed that. The first cure of hairy cell leukemia came from my laboratory. Not that I'm not looking for credit for that, but all of those discoveries that were so important and have really played out importantly, are not greater than the potential for this magnificent new field, which is to peer into the fundamental basis of our lives as we exist, the bioenergetics of our existence. Cancer is nothing more than a bioenergetic disease. And if we could get to the basis of the cancer bioenergetics, which I feel more confident today than I ever did before, then we can cure it. And the beauty of that is we can probably cure it without toxicity because cancer has extraordinary vulnerabilities. It really does. Cancer cells are extremely stupid.
They're resourceful, but stupid.
Cancer is really stupid, But cancer is stupid the way that a really big guy can beat your brains in. He may have an IQ of 60, but he nonetheless knocks your block off because he's a big, hulking, dumb guy. And that's cancer. Cancer is stupid. It relies upon metabolic vulnerabilities. There are approaches to cancer that we're opening up now that could change everything about this disease. What's more interesting, I think, is that long before cancer shows up and long before we start treating it with drugs, we can find that tendency, that biochemical tendency, so that instead of waiting until this multi-centimeter mass shows up in your breast or colon or pancreas, you find the signatures in the blood suggesting that it's on the way. So a little bit like, actually quite like, if you've ever walked into someone's home and you smelled something cooking, that quantity that you're picking up is 1 in 10 to the 8th, 1 in 10 to the 9th, 1 in 10 to the 10th particulate matter in the air, yet you know what they're cooking.
Yeah.
You go, pizza or garlic bread, or, you know what I mean? And it's because that detectability level
amazing
long precedes your sitting to dinner. You get it before you get it. So the cancer idea here, well, we just got our CLIA last Thursday. We just had our CLIA.
Congratulations.
So we're now going to be able to roll this technology out for our patients and for people interested in looking at metabolism. So that's not yet, but it'll happen in the first quarter of 2025.
So excited.
In any case, what we think now, and what we said in this paper, I was actually rather proud of this paper. What we said in this paper was that cancer is a manifestation of inborn-like errors of metabolism. You carry lifelong deficiencies and predispositions that manifest through a life of badly lived existence. We give ourselves disease because we have certain frailties and deficiencies. And if we don't know about them, then we don't know to avoid phenylalanine or to eat more. Strangely, one of the things I'm finding is some people need more carbohydrates.
Right.
You would never have heard that from me a few years ago. But now I'm recommending, I've had people come into my office and I say, you need some more complex carbohydrates. Take a snack before bedtime. It's amazing. Yeah, I know it. Anyway, so what we're finding and what we notice is that these inborn errors of metabolism are so ingrained that the quote from the paper was that cancer is a local manifestation of a systemic illness.
Wow.
And the way that we proved that, I may have told you this, we took the metabolic signature of colon tissue.
It's huge.
And compared it to the metabolic signature of the adjacent colon cancer. And when we looked at the metabolite ratios, the normal tissue profile could predict response and survival for the colon cancer. That is, the person's physiology predicted outcome. And we've seen this over and over again. We've seen this in ovarian cancer. If you want a story, if you want an interesting, this would probably resonate to your audience. Some years ago, I was running my protocol on ovarian cancer. We first published a major treatise of 1,200 plus patients at breast. I then wrote a prospective study in ovarian cancer and accrued a little more than 50 people prospectively. And we got tissue and plasma.
Wow. Yeah.
We looked at the tissue to assess drug responsiveness, and we looked at the plasma for metabolic signatures. One of the patients who was accrued was very, very nice, very vigorous woman. Who was very interested in natural therapies and diet and health. And when I met her and I studied her and I got her blood and she consented to the study, I said, well, it's very nice to meet you. Good luck with your surgery tomorrow. We'll look forward to get your tissue so we can process it. And we'll get the metabolites figured out. And after the study closes, I'll tell you what we found. Now, this was a prospective study and it was blinded.
Wow.
So I could not I could not look at her data. I mean, to adhere to the protocol dictates, I could not look at who she was. I could just bank the data, which we did. It was all blended. 5 years later, the patient, this is so interesting. The patient said, I'm not taking chemo. And I said, you have stage 3 ovarian cancer, you'll die. And she said, I'm not taking it. And I said, this is insanity. You have to take it. Not that I love chemo, but we know that epithelial cancer, the most epithelial ovarian cancer, the most chemosensitive. So if there's any disease where you probably ought to look at chemotherapy, lymphoma, testicular, ovarian, some breasts. So I said, well, look, I think you ought to take the chemo. And she said, no, not doing it. It turns out that the gynecologic group who she was working with was so unhappy with her that they discharged her from care.
Wow.
So she didn't have a doctor. So she returned to me out of the blue and said, I remember meeting you at the hospital when you recruited me your study and blah, blah, blah. And I'd like you to follow me. And I said, well, why? And she said, because I didn't take chemo. And I said, that's crazy. And she said, well, I wanted somebody to follow me. I said, okay. So every 3 months I did a CA 125.
Yeah.
And year after year, she didn't recur. Now, she was on a very abstemious diet, very closely monitoring a lot of features of her well-being and her diet and her nutrients and all this stuff. But she didn't recur. About 3.5 years later, she had a slight bump in CA 125. I found a single focus of disease in her retroperitoneum, base of her abdomen. The surgeons didn't want to take it out, so I sent her to radiation therapy. It was the only spot I could find on a PET scan. We radiated it, and she's never recurred. Now, the reason I tell the story is about the 5th year after I met her, after everything had gone so well, I said, I met her in my clinic. She came to visit, just a regular follow-up. And I said, I've always wondered why it is you survived. I've never seen a stage 3 ovarian cancer not die of ovarian cancer if they don't take treatment. It seemed impossible. And it suddenly dawned on me, I had her plasma.
Yeah.
I had her plasma. I had her results. And I had not realized it because it was a blinded study, but we were publishing the study that month.
Wow.
So now I could go back and connect her barcode to her data. And she fell in the no cancer group.
Wow.
She fell in the healthiest ovarian cancer group. Now, the reason that was important is that when we did these studies and we followed it prospectively, women with a favorable metabolism in the plasma, in the body plasma, had a 5-fold higher survival 5 years later.
Interesting.
Not based on genes, not based on DNA, based on their biochemical well-being, their metabolism.
I love it. What I love about this most is that everything you're speaking to, in the words I choose to describe it, is about the terrain. The environment in which the cancer expresses is really what is feeding into that metabolomic fingerprint that you're speaking to. And so, one of the things, in full transparency, my hope is to have Dr. Nagourney take my blood, because I'm also one of those kooky patients who did not take standard of care for my stage 4 ovarian. And we suspect that I have a particular fingerprint, right? And have spent, much like the patient you just described, the past 33 years being very diligent about my testing and my lifestyle and my impact, because it's not been a linear process of like, I didn't go from I have cancer to I don't have cancer. It's been a circuitous path all the way around, but it's always been relatively maintainable and stable. And so we're curious about that and doing deeper. But I think what I'm most excited about, Doc, is not only are you able to help people who are already diagnosed and dealing with this, to help them understand that both, that lunar shot view, as well as that go and have the cup of coffee view that you so beautifully described. You also are developing and putting into the market very, very soon a very early diagnostics tool that will allow us to do the real cure for cancer, which is prevention. Mm-hmm. And I'm very excited about where that will go. Can you tell folks where we can learn more about you? Go and read your papers, learn about what you're offering both now and what's coming here in the early part of 2025. Where can people learn more about the work you do?
Well, Nasha, thank you. And the thing is that we do a lot of things. So my laboratory has a lot of moving parts. The original application of our concepts were cellular biology.
Right.
I'm basically a cancer biologist, and I'm interested in cancer biology at the cellular level, whereby we measure your cells. So if a patient is going to go through surgery, whether they have circulating blasts from leukemia, whether they're going to have a bone marrow aspiration for myeloma, whether they're going to have a lymph node excision for breast cancer or a lumpectomy or whatever, and there is a question as to what to do. Now, I don't generally try to get too deeply involved in cases where it's easy. If you have...
That is very true.
No, because if you have a small ER-positive breast cancer, and you're node negative, I wouldn't probably change anything. And I don't think there's a rule really for the easier cases. If you have a standard risk chronic lymphocytic leukemia, the treatments have become quite good. So yeah, those cases probably don't immediately need me. But the moment you move from the low-hanging fruit of cancer to everybody else, which is about 90% of what we're dealing with, the colons, the pancreas, the gastric, the bile duct, intra and extrahepatic, the high-grade lymphomas, the sarcomas, the gliomas, the diseases where we're having almost no impact. Pancreas, for me, is if there is a disease that I would like to have an impact on, is pancreatic cancer. My first metabolomics patent came from pancreas, and it was just an accident almost. We were publishing our original breast cancer paper. I had conducted some preliminary studies collecting other cancer blood plasmas. And when we submitted our paper, we submitted a patent that incorporated our earliest pancreatic data, and that has subsequently folded out into our first patent and also our subsequent most recent publication. Anyone who's interested in reading these papers, if you just Google my name.
Yeah, you're everywhere.
And you put in what disease you're interested in. If you look Google pancreatic, you'll come up with our most recent paper from Metabolites. If you put in my name and metabolism breast, you'll get our oncotarget paper. One of the really, I think, good papers is that gynecologic oncology paper I published with my colleagues from here from UC Irvine.
Is that the 2021 paper?
That was 2021, yes.
Yeah.
And that paper, to me, is extremely interesting because it's a prospective evaluation of metabolic signatures as predictors of survival. And it's very profound and it's statistically significant. And it means that really, if we were to focus more on physiology, metabolism, metabolomics, we might really get a handle on cancer. Now, when you mentioned to me how people can reach us, as I said, there are sort of two things that we do. The Nagourney Cancer Institute is a clinical therapy program, largely focused on the more difficult cases. I mean, I will help anybody, but my time is limited. So I try to address cancers that are so complicated and so, difficult for the general practitioners to deal with, like metastatic pancreas. Nobody knows what to do. Metastatic colon. Very few people know exactly what to do. Metastatic lung cancers, things that really are potentially lethal, that you're measuring life expectancies in 1 or 2 years. Those are the patients that you can push out 3, 4, 5 years. I'd like to say I can cure them, cure occasional patients, but I certainly help patients. So that's the Nagourney Cancer Institute. And you can just Google Nagourney Cancer Institute and you'll see the website, you'll see the blogs. If anyone's interested, today's blog is on a woman with lung cancer who I can't believe how well she did once we gave her the right thing. And it's about the difficulty in giving people the right treatment, how Byzantine our system is. Now, on the flip side of the coin, and the one that we're just rolling out, in the last years, we've developed a small startup company we call Metabolomics. Now, chose the term metabolism, spelled metabolomics, but the last letters are MYC instead of IC, it's YC. And the reason is because as we got involved in these studies, particularly in our original breast studies, we began to realize that the gene that keeps popping up is the MYC oncogene. So metabolomics turned out to be an increasing measure of how changes in the way we use this particular gene manifest as cancer. So we started a company called Metabolomics. Yeah, it was spelled like metabolism, but NYC. And there's a website. It's just a basic landing page. But within the first quarter of 2025, those services, which are plasma-based, my original Nagourney Cancer Institute is tissue-based.
Right.
So you need to get a surgery, you need to get blood drawn or a bone marrow aspiration or a lymph node biopsy. Our work in the plasma is now rolling out as a blood test where we can characterize how metabolic changes may be predisposing not only to cancer, but to cardiovascular disease, metabolic syndrome, maybe dementia, Parkinson's disease. We're just in the process now of collaborating with a group in Brazil that we work with on Parkinson's. We think we have a signature for early onset of Parkinson's, which could maybe offer us interventions. See, the beauty of this, if we imagine that cancer is a local manifestation of a systemic illness, and if at an age where your systemic illness is detected before you get the disease, not just cancer, but alterations in many different metabolic signatures, you could arguably supplement with the appropriate micronutrient, alter your dietary intake, examine your lifestyle, sleep patterns, exercise patterns. Like we're finding people, for example, who are manifesting inflammatory signatures. And I'll say to them, and they're very healthy, fit-looking people, and I'll say to them, what's your lifestyle like? Oh, I eat this and that, yeah. And I'll say, what's your exercise profile? Oh, I do, marathons with it. I don't know that the human body is designed for extreme exercise. I think the human body is designed for more measured exercise. So there are reasons, like I exercise a lot. I do rowing and I do weights and I do all sorts of stuff. But I don't do it to excess. I don't do it to the point where it hurts.
Right. Not the endurance.
Yeah. What I'm seeing in people's blood, particularly the tryptophan-guanine ratios, is that they're causing inflammation.
Which then will spike insulin, which then will spike other patterns. It's a cascade that is far more damaging than good.
So yeah. So more, it's interesting. I have a patient who I cured and I'm very proud of. He had a horrific triple negative breast cancer. And she came to me as a Greek woman. And she came to me 5 years after I had treated her. She went to complete remission, a pathological complete remission, and she's fine. I don't even really follow her. She comes once a year. She insists on seeing me once a year. But she gave me a present. I probably mentioned this to you before. She gave me a statue of Hygeia, the Greek god of health.
So love this.
And she said, you must have this statue. You must know that you are doing the right thing by this God's dictates. And I said, well, what do you mean? And she said, well, everyone interprets the sayings from Hygeia as everything in moderation. She said, the correct Greek translation is everything in the right measure.
Wow.
And she said, the reason you cured me isn't that you gave me a moderate dose, but you gave me the right thing for me. And that's the lesson that I've learned, is everyone is different and every cancer is different and every patient needs a different treatment that's right for them. And every patient needs a diet and an exercise program and a lifestyle and a sleep pattern that's right for them. Now, I don't want to overstate what I can do. I don't know all the features, but we know more and more that we're finding signatures of health. And for the first time, we can measure the biochemistry of life. We have a metric of health. And that's where I think the Metabolomics platform, go with a Y, that's where I think the Metabolomics platform is going to be so important. I hate treating end-stage cancers. I mean, I treat them as best I can, and every once in a while I cure them. I fix a lot of them. We published a paper some years ago. We had a 52% objective response rate in untreatable cancers. But it's not a cure rate. It's a response rate. So it was an international collaboration, and it was quite good. It was hundreds of patients, but it was response. So people lived longer. I had an interesting conversation. This is actually very emblematic. I got a call today, and I looked at the chart and I recognized the name. The woman had come to me 5.5 years ago with breast cancer. And she sent me I think she came here. We did a liver biopsy. Yes, she did. I met her. And we did a study and we recommended treatments, and I forgot. I didn't forget about her. I just didn't hear from her. She was done. We did our thing. So she called me today and I talked to her and her husband. And I said, "Oh, how are you?" And she said, "Well, I'm pretty well." And I said, "Well, what happened?" And she said, "Well, after I went on," she had ER positive. After I went on hormonal therapy, it stopped working pretty quickly. And I don't do a lot of hormonal therapy measurements. So I didn't really weigh in on whether she'd take hormones, only ER positive, or as I recommend hormones. So she said, "Well, I broke through very quickly." Obviously, with metastatic disease in the liver, hormones become less and less.
Right.
So she said, so the doctor put me on capecitabine, Xeloda. So I said, oh, that's the number one drug on my list of chemotherapies. And then I said, so how did it work? And she said, it worked beautifully for 2 years. Perfect. Great. Excellent. I said, well, what would you do then? And she said, well, the doctor put me on alpelisib, which is a phosphonol kinase drug called Piqray commercially.
Oh, God. Yeah.
And I looked at my profile and they said, oh, yeah, that's the second drug we recommended. How'd you do? Oh, she said, I did great for a couple of years. And so I said, wasn't your doctor pleased with your progress? And she said, well, he told us that he gave us what he would have given anyway. So I thought to myself, let me think. Piqray. No, wait. Piqray didn't exist in 2019. It wasn't a commercially available product. Secondly, he didn't have the phosphonol kinase mutation, which he found, until 2 years after I had recommended the drug.
Interesting.
So strangely, he was he was sort of unwilling to admit that we were right all along the way. Like I would have thought he would have said, gee, that's pretty darn good.
Yeah.
But he had to squirm his way out of suggesting that it should work, which was funny. I will, if I might bore you with a related story. Is that okay?
Absolutely, yeah.
Some years ago, when I was first in practice, one of my young colleagues with me was leaving for a vacation, and he said to me that he was leaving a patient who was an end-stage CLL patient. 15, 20 years ago, CLL could be a real bugger. And we didn't have the tyrosine kinase inhibitors, that we didn't have the BH3 mimetics, we didn't have obinutuzumab, we didn't have anything. So people got chlorambucil, and then they went on experimentals, and then they died. So he said, this guy's had experimentals. He went to USC, which is a major center nearby, and he had something called homoharintonine. He had all these different drugs, and he was progressing despite everything they could think of. So he said, he'll die probably by the time I get back. Please just take care of him. So I went in and I met this very nice, very humble, emaciated black gentleman. He wasn't old. He was in his early 60s, I think. And I said to my colleague, I said, would it be all right if I took a blood sample? Because I was studying CLL. It was the principal disease I worked on. For years, I studied CLL. So would it be all right if I used his blood? And he said, fine. So I consented him and I got his blood sample. And lo and behold, he was sensitive to corticosteroids. Like prednisone, cortisone, dexamethasone, prednisolone, right? And I thought, this guy's got to have had steroids, right? Which he did, of course. But it had been 8 or 10 years in the course of the, chlorambucil with prednisone and prednisone with the Kristen and Cytoxan. So he had been through the gamut of different prednisone-based therapies, and they had largely left it behind. But here, his current disease was highly sensitive to prednisone. So I went back, I was covering, so I went back and I gave the guy prednisone. And within a matter of days, he got all his lymph nodes melted away. His white count returned to normal. We started eating and he went home. So my colleague returned from his vacation in the Adirondacks and said, well, what happened to Mr. Smith? But I can't remember his name. And I said, oh, it's a funny story. I said, we ran a test on him, and oddly, he was exquisitely sensitive to dexamethasone in vitro, so I gave him prednisone, and he got a little bit of one. And the guy said, prednisone, huh? I could have done that.
And herein lies the problem. Coulda and doing it are very different things. And
He didn't know to do it. That's the point.
this is why this conversation with you has been so important today. You are highlighting what we teach to all of our clinicians, advocates, and patients around the world, which is the concept of test and assess before you address and don't guess. Like, very basic, right? It's a simple methodology. You bring more tools and more methodology to the table for us to really personalize medicine. You have been at this for probably my entire 33-year journey for my own health and that of the things I've learned over these years and beyond. But you are the one who has stood up in the resistance, in the ridicule, in the even the blatant attacks on your character, your knowledge. And yet you have been a pioneer in this for decades. And what you're about to unveil into the world in early 2025 is nothing short than another huge advance, in my opinion, in metabolic health in general and cancer in particular. I'm incredibly grateful for your humble knowledge, your amazing way of telling a story, the metaphors that have landed so many concepts for me that just light bulbs going off everywhere. Dr. Nagourney, I look forward to learning from you for many years to come, referring patients to you for many years to come, and I'm so grateful for the work you do.
Well, thank you for having me, and we're very happy to work with you. If you and your many colleagues are interested in more, Metabolomics is the website. It's just a landing page now, but it has all our publications. So they can get a sense of about 28 papers in the field. And the Nagourney Cancer Institute is where we focus on really addressing cancer on an individual basis, getting patients. And I don't want to overstate it. It's not a perfect test, but on average, it doubles response and can add about 44% to the likelihood of survival. So we use it every chance we get.
Beautiful. Beautiful. Doc, incredibly grateful. Thank you.
Thank you. Thank you for having me. My pleasure.